stigma seems like a column in the middle of the room that you can't do anything about. But really, stigma, if you look it up in the dictionary, is negative attitudes. And negative attitudes we can change. And we try to do that by partnering with communities, by talking with legislators, by bringing healthcare providers in together. So those barriers between academia and lawmakers and people with lived experience are really breaking down. We're building an entire community with all those people involved.
Welcome to System Catalyst, the show that cracks the code for making the world a better place. I'm your host, English Saul. Today, we're joined by Dr. Jill Harkavy-Friedman and Vic Armstrong, two leaders at the forefront of suicide prevention research, advocacy, and system change. Dr. Jill is Senior Vice President of Research at the American Foundation for Suicide Prevention, AFSP. She's also a fellow of the American Association for Advancement of Science. She founded the Adolescent Depression and Suicide Program at Montefiore and has spent many years on the faculty at Columbia University. With decades of clinical and academic experience, she has helped shape much of what we know about suicide prevention. Vic Armstrong is AFSP's Vice President for Health Equity and Engagement. Before joining AFSP, he served as North Carolina's first Chief Health Equity Officer, led the state's Division of Mental Health, and was Vice President of Behavioral Health at Atrium Health. He's a nationally recognized advocate who brings a strong systems and equity lens to his work. Dr. Jill and Vic, welcome to System Catalyst. We're so excited to have you. And before we jump into some of these questions today, I also wanted to highlight that you both have a podcast. We're sort of in the same podcast family here with Hueman Group. So before we jump in, do you mind sharing just a little bit about each of your respective podcasts?
Sure, I can go first if that's okay.
Perfect.
And first, thank you so much for having us here. I'm really looking forward to the conversation. So Ask Dr. Jill is the podcast that I host, and it's really an opportunity for people to ask questions, some basic questions, and we try to answer them using evidence-based and scientific information. And we try to field questions that are important to the public and where there's sometimes misunderstanding or new topics that need to be addressed.
Amazing. Awesome. What about you, Vic?
Yeah, thank you. I echo Jill's comments about just being very thankful for the opportunity to be here. My podcast is called Strong Talk, and Strong Talk is where I have a conversation with people talking about challenges and opportunities to improving and increasing access to mental health resources, particularly for historically marginalized communities. It's a one-on-one conversation. I love to talk with, especially with people who have turned their pain into ways to help other people, and who want to share their story in ways that can help other people to overcome whatever challenges they may be having.
Amazing. Well, I highly encourage all of our listeners to tune in to these two podcasts. Thank you guys again for being here. I'm so excited about this conversation. So to kick us off, Vic, I know that you and I have similar threads, obviously, as it relates to North Carolina. Mm-hmm. I'm currently in North Carolina. You've spent a lot of time here, doing a lot of work here. Now, remind me, were you born in North Carolina? Were you raised in North Carolina?
I was born and raised in Plymouth, North Carolina, which is a small town in northeastern North Carolina. Very, very rural community. Last I checked, which was within the last 6 months, the population of my hometown is about 3,300 people. So very rural.
I know it only because I too grew up in a very rural kind of small town in Wilmington, North Carolina.
Yes, I know Wilmington well.
Yes. And so it's kind of like you have to be in a rural small town in North Carolina to know that there's other ones that exist. It's not common knowledge.
Especially east of I-95. That's where it gets really rural.
It's true. Yeah. It's very true. So Vic, I'd love to just hear a little bit more about your upbringing.
Yeah.
You were the son of a preacher.
Yes.
How did that influence really the work that you do today?
there are so many things about my upbringing that influenced the way that not only the way that I think about life and the way that I approach life, but also the way I think specifically about mental health and suicide. When you consider that I grew up in this very rural community, in rural North Carolina, son of a preacher, also being a Black male, there were things that I heard repeatedly growing up that really shaped the way that I see at that time, how I saw mental health and suicide affecting me and affecting my community. When you think about it, growing up as a Black male, I was really socialized not to talk about mental health, not to talk about experiencing anxiety or depression. It was impressed upon me as a young person that for a Black male, the way that you navigate the world is you keep your head down and you keep your mouth closed, and you don't talk about your pain. You don't show vulnerability. You don't want to come across as weak, and to talk about anxiety or depression would have been perceived as weak. Then you add to that I was the son of a pastor. And so now I'm getting an additional message that if you are experiencing anxiety or depression, you don't need to talk to a therapist. You need to pray more. You need to have more faith. I went to church every Sunday. We sang a song when I was growing up called Jesus on the Main Line. We didn't sing a song called Therapist on the Hotline. So it was reinforced to me that when you need help, you go into prayer. And then on top of those two things, you add that I was born in this rural community. And in a lot of rural communities, there is this perception that you're supposed to be strong. You're supposed to pull yourself up by your bootstraps. You don't ask for help. I was raised growing up working in tobacco fields and doing things like that. So it was a very, very regimented kind of environment where you were taught that you are supposed to always portray strength, and you're supposed to always be able to do for yourself. You don't depend on other people. So all of those things impacted me, and I apply those things when I'm working with communities today, because it just reinforces in me that there are things that were taught to me and that I was socialized to see and socialized to believe growing up, that much of it was behavior that had to be unlearned in a lot of ways as I got into the field of mental health and suicide prevention.
It's just really enlightening. And I think that it speaks to a lot of what we're going to talk about today. And Jill, it brings me, kind of to ask you, you started your research really around, I think it was like 1985, around the time of your research on suicide prevention. And so what did we know? What did we know at that point in time about suicide and suicide prevention when you first came kind of into this world?
Well, we didn't know a lot. We were starting to study it. What we didn't know was, like our whole program, which is based on Talk Saves Lives, the thinking was don't use the word because you could actually make people suicidal. There was some growing understanding that it might run in families. There was a little bit of understanding that having access to means may contribute, but the idea that it could be prevented was unknown and unheard of. The thinking was if someone wants to do this, they're just going to do it and there's nothing you can do. And don't say the word, because if you say the word, you could actually make someone suicidal, which shows how simplistic the understanding of suicide was. And I think actually a little disrespectful, because people were really suffering when they were suicidal. And so I got into the field because they wanted to learn more about teen suicide. And when I was in college, it was that kids don't get depressed. And so it was just starting to get established that maybe kids could get depressed, but they certainly don't take their lives. But we knew, in fact, that wasn't true, but we didn't know how many kids. So I got into the field because essentially nobody else would ask kids in a survey in school, have you thought of taking your life? And so I was a young PhD and was like, okay, I'll do that. And also to start a clinic for kids who were thinking of suicide. That was another one. Oh, you can't put suicide in the title because you'll make people suicidal. And I was like, well, first of all, not everybody who's depressed is suicidal, and not everybody who's suicidal is depressed. So we need it in the title to let people know we're here. And that was unheard of. I had to fight really hard for that. So we were starting to learn that maybe the brain was involved in suicide. But the thinking was it was an active, rational choice that once somebody decided you couldn't do anything about it. And none of that, it turns out, is true.
English too, if going back to when I think about growing up, one of the things that was also a factor is not just the things that were said to me growing up, but the things that were not said. Because when we talk about where we were in terms of research and all that and, during that time, part of what I also experienced growing up is while I was getting this misinformation from within my community about how I was impacted by mental health or not impacted by mental health and suicide, there was no narrative coming from outside the community. There was no, at that time, there was no AFSP or MHA or NAMI or any organizations saying to my rural community, my faith-based community, or my Black community there in this little corner of Eastern North Carolina, there was no organization saying, no, this is about you. This really is. We want to reach you as well. And so it really kind of reinforced to us that if you're not reaching into this community, we must not be your target audience. So it must not be about us. All I really had to go on was the misinformation that I was receiving. And so I took that to be truth. And so, and again, I think it influences the way that we approach this work today, because we do recognize that there are messages that are embedded in the fabric of communities. And oftentimes we're having to combat that message with research, with data, with truth, and it just makes the work more challenging, but it can also make the work more rewarding when we're able to reach those communities.
So I think that's it's a really key point too, Vic, and part of what I understand AFSP does is changing, in the sort of whole of changing the system, it's shifting the language and shifting the cultural narratives. And so maybe, Vic, can you tell me a little bit more about how AFSP does that?
Sure. Well, one of the things, we do recognize our influence in this space. We are the nation's largest suicide prevention organization. We're the largest funder, nonprofit funder of suicide research. So we recognize the influence and the power that we have to create messaging in this suicide prevention space. And so one of the things that we've done is we're starting to look at not just how we can reach more people individually, being that our mission is to save lives and bring hope to those impacted by suicide, but also how can we move the needle in the field in terms of how we're thinking about suicide prevention? How can we present it as more of a population health approach and not thinking about this one size fits all model? So one of the things that AFSP is doing and has been doing over the past several years is really thinking about how we can work alongside communities and how we can allow communities to lead us in this work of creating resources that speak to them. Because we recognize that communities know best, not just what resources are culturally relevant for them or culturally relatable for them, but communities also know best which resources they're going to be willing to utilize. And so what we've begun to do is to reach out to people who represent these communities and who represent the intersectionality of these communities, recognizing that no community is a monolith, bringing these people to the table and allowing them to help us to create resources that speak to their communities. One example would be, we've had for years our signature I always call it kind of our Suicide Prevention 101 program, our Talk Saves Lives program. And a couple of years ago, we took that framework of Talk Saves Lives and we brought in people from the Black community. We brought in researchers, we brought in advocates, we brought in people with lived experience, and we created Let's Save Lives, which is an acronym: Listening, Empathy, Trust, and Support Saves Lives, an introduction to suicide prevention for the Black and African American community, or the Black and African community. And the reason that we did that was because we wanted to create a resource that the Black community could see themselves in. We've created Talk Saves Lives for the Hispanic community. We have resources for veteran communities. And so we have tried to create these resources that speak to specific communities, recognizing that not all communities have been socialized to see themselves in this framework the same way. Not all communities see the impact of suicide on their community the same way.
Wow. So I think that this is super interesting. And Jill, I'm wondering if you can take us to kind of the 1,000-foot view here. And Vic, what you just said also is that there's so many different groups of people and subgroups of people who are very directly impacted by suicide. And so, Jill, I'm wondering if you can sort of highlight, kind of at a top level of like, what does AFSP do and how does it sort of work to address all of these different groups? You have vets, you have the Black community, you have teens, you have, how does AFSP work to sort of target all of these groups in the way that they need?
So I think we have to go back to the beginning first and start with the idea that it was actually ASF at the time. And AFS was started by a small group of families and researchers who just felt the families had lost someone to suicide. And they just felt we have to understand this so that we can prevent it. And at the time, that was really different from, it's just going to happen and just sort of go with it and there's nothing we can do. So it was groundbreaking at the time. But it started with researchers and family, but very quickly realized that we also have to educate the public. And so that was in 1987. And so we already started with the research, but also what can we tell the public about how to prevent suicide? And as the body of knowledge has increased, has grown, we've learned more and more that not everybody is the same. That there are some underlying contributors to suicide, and there are some pretty frequent stressors that can precipitate suicidal behavior in a person who has those contributors, and that limiting access to lethal means make a difference. So what does that mean for us? Well, first of all, it means there's 3 places to intervene, both whatever the underlying factors are, managing social stress, and limiting access to lethal means. So if you take that up a notch, what that means is we need to educate people about what does it look like when somebody might be at increased risk for suicide. And that's where the education really started. And so we started having programs. But then it's like we can educate people, but we also have to do something about it. And so that's when we started getting involved in policy, using the research and the political will of people affected by suicide to then say to lawmakers, hey, this is unacceptable. We have to devote funds and attention to things like the research that's going to help us understand more, to services and clinical care, to access to lethal means. And we have to get a body of people involved. So now you have the research, the education, the advocacy, and then the last part is the support for people affected by suicide. So the bird's eye view is we tackle it from all angles. And we want to create a community and policies and work that understands suicide so that we can prevent it when we can and help people who've been affected by it.
Wow. So I want to hone in on this sort of community piece of it. And Vic, you spoke to this in really elaborate, thinking about the program specifically. But, this type of systems change really only works when the community is an active part of it. So, Vic, what have your experiences been with engaging these communities around suicide prevention? And can you talk a little bit about some of the kind of barriers or hesitations that have existed and how that has happened over time?
Yeah, I think some of the bigger barriers are really based on history. It's the way that communities have been approached and engaged, oftentimes by systems in the past, that can make them a little bit leery. It also, I think, depends on how you communicate with communities, because what has happened historically is that for systems and large organizations, we've really kind of owned the language that we use when we engage with communities. So we use words like partnering with communities. We use words like collaborating with communities. What we don't often think about, though, is, and because we haven't had to, is that collaboration and partnership looks different through the lens of a community than it does through the lens of an organization. And so part of where we have to start is recognizing that we come from a very, very transactional space. We come from a space of, you get into a certain diagnosis, I can prescribe you certain medication, I can authorize certain services for you. If I provide a certain service for you, I can check off a certain box. If people reach a certain level of incapacity or sickness, or however we want to frame it, they can get a certain level of services. But communities are much more relational. They don't think in terms of a transaction, they think about relationship. And so part of what we've had to do in building these resources with communities is we've had to create relationships with communities. And that's very different from the way that we have traditionally done things. It's easier when you can say to a group or an organization, I have these programs. If you want to contract with us for this amount, we can do this. Or if you want to contract with us, we will do this, this, and this, and this amount of time. It's very different when communities are saying, this is on our timeline. And, this is what we want it to look like. And so what's been different is where we often have to start is bringing the folks to the table. One of the things we have to consider when we talk with communities is, where are communities willing to engage and willing to congregate? Who do communities perceive as a helper? Who are they willing to go to? One of the reasons that we created a program called Soul Shop for Black Churches is because we recognize that in the Black community, for a lot of Black people, they are much more likely to go to a faith leader than to go to a psychiatrist or a psychologist. And so we created that as a point of access because we know part of the way that the faith-based community in the Black community has been socialized is when you're struggling, you go to your pastor, you go to your faith leader, you turn to your church. And so rather than to say to them, that's wrong, what we say is, how do we create the type of resources that they need in that space? How do we correct for the misinformation by providing access to the real information, to the truth? And so that's where we have to start from. But, beyond that, it involves actually bringing those individuals to the table as a part of the planning process, whether it's been our work with the construction community. We're currently doing some work with the AAPI community. It all starts with, let's bring the communities in and look at and let them inform us on what works best for them. For some situations, as I explained with the Let's Save Lives program, it's been, let's bring these folks to the table. Let's show them a framework and see if we can build something from that framework. Right now, where we are with the AAPI community, there are some work that's happening in that community. And so what we're starting with them is, let's understand what's already happening. And then how do we come alongside that work? How do we help to build upon that work, as opposed to coming into a community and telling them, we're here, we've got all the answers. You just need to listen to us and do what we say. It's really more about, you tell us what works for you, what you're willing to utilize, because at the end of the day, our goal is not to further the AFSP brand. Our goal is to save lives and to bring hope to those folks that are impacted by suicide.
And so, Vic, I think that, in my experience too, sometimes we have an idea. Sometimes we have an idea, be it based on research, based on experience, based on whatever it may be, of how we might be able to show up and help, or show up and sort of, offer a solution to a community. And often, what I find is if you have someone coming from outside the community, showing up and offering a solution, a lot of times there's kind of tension, because the community, right? We've learned that the community often knows what they need, and what resources they need and how to use those resources. And so can you give an example of a time that maybe in your work you've seen that happen, where maybe you or AFSP or someone has sort of come with a solution and an adaptation had to take place?
Well, even when we started with the Let's Save Lives program, what we started out with was, this is our Talk Saves Lives signature program. How do we embed things in this program that will make it appeal to a Black audience, to the Black community? What we immediately heard from that group was, we don't want you to take something and just add a little bit here and there to make it fit us or to appease us. We want to take it down. We want to strip it down. And so what we ended up doing was, we leave in, again, those core components that are key to suicide prevention, but everything was stripped down, even to the point where one of the first decisions we came to was, the group said, we don't want to call this Talk Saves Lives for the Black community. because talk has never saved lives in the Black community. So we wanted it to come to be, called something different. And so one of the first things we did was we decided we're not going to call it Talk Saves Lives, because that group said that was a non-starter for them. And so, and we've run into that with different groups, that we go into it with the things that we know and the things that we understand. And we are experts in suicide prevention. We're not experts in everybody's community. And so there are those times when I first started working with the AAPI community a couple of years ago, they were having a conference in Atlanta. And I had one of their leaders approach me and say, we'd love to have you come and speak as a keynote at our conference. And so I was thrilled to do so, because we were in the early stages of trying to even build relationship with the AAPI community. They came back to me about a week later and said, well, we don't think we're ready for an organization that has suicide in the name. We're just not there yet. So we're going to rescind that offer. And what I had to do then was to say, okay, that's okay, but do you mind if I just come? Can I just show up? I don't need to be on the program. Can I just be in the audience because I want to learn from you? It meant so much to them. And that was one of the things that I think has really made them more accepting of me, because I'm not coming to them as someone who's saying, I will come on my terms. But what I'm saying to them is, I will come on your terms. And if that means you don't want me there at all, I will not show up until you say it's okay.
Wow. So that's such a good example of a way in which that, being a system catalyst, so much of the journey is just trying to participate and learn, even as a passenger in this system, to really understand at a community level how best to serve the community. So Jill, I am wondering, you communicate, obviously you guys are deep in collaborating with community, but you also are collaborating with governments and experts and scientists. And I believe it was AFSP that published the first study on suicidal thoughts. And I'm wondering if, Jill, you could tell us a little bit about that study and what it also has been like to collaborate kind of with the scientists on this front, and how to bridge the science and the community components.
Yeah, so actually that was a study that I did, which brought me immediately into the fold of AFSP.
Amazing.
Because I went into high schools, and instead of starting with kids who had already made a suicide attempt, and asked them, have you thought about it? Have you made a plan? And the point was that AFSP just kind of got a government workshop, NIMH, and I was there, AFSP was there, and immediately David Satcher, and this is the thing, it's not government or academia or everybody's been touched by suicide. And so David Satcher got up and talked for the first time about how he lost his father to suicide. And that's one of the things that bridges the gap, that suicide cuts across every demographic, every life station. Almost everybody has been touched by suicide in some way. And so when we go to Capitol Hill and we advocate and we meet with congressional staff and Congress people, they have been touched by it. They have constituents who have been touched by it. And I think that's one thing that has really helped to keep suicide prevention at the forefront, that we are all in this together. And so it's a matter of gathering the people together, and that includes people with lived experience, that includes researchers, that includes lawmakers, and many times they're all, intertwined in the same group. And just like Vic is talking about how you have to bring the community together. So we have worked very closely with the National Institute of Mental Health. We've worked very closely with the government. There is a will across the government to address mental health and suicide prevention, I think in part because so many people have been affected. But starting that conversation, that was the AFSP lift, like going in and saying, we need to talk about this, and I've been going to advocacy days for many, many years. In the beginning, it was like, don't use the word, I'm so uncomfortable. And very quickly, with repeated knowledgeable visits, we come in now and they say, let me tell you what we're doing for suicide prevention and mental health. So I think we you just like working in the community with information and education, you still have to meet people where they are. We do some boning up on words, like we don't say committed suicide anymore. We say died by suicide because it is a health condition. It was actually, it's still a crime in some places, but it was actually a crime in the United States, I think, till 1974. So we say died by suicide. We don't rate suicide attempts as, oh, that was successful or failed, because like to say you were successful because you died and failed because you lived makes no sense. It's just a suicide attempt. So we all had to get the same language on board, and we're still working on that. And by the way, we're still working on decriminalizing suicide in other countries. So it's still the same idea that we're all in it together. We need the voices of people with lived experience to help educate. AFSP we started from people who lost people. And the thing is that information has changed a lot of how we talk about suicide, what we work towards. And so I've become really aware, and I think we all have become aware, that when I started, I used to say people thought suicide couldn't be prevented. There's nothing you can do if somebody wants to do it. And so we would spend so much capital on suicide can be prevented, it can be prevented. And then the loss survivors came up and said, well, not always. Like, don't make me feel like I did something that led or didn't prevent the death of my loved one. And that's so true, because we can try as hard as we can, but we can't prevent every suicide. And so our language has to change around that. But we have to keep trying, we have to keep learning. And so having loss survivors finally coming out and talking about their experience has helped the legislation, has helped the researchers. I know the word stigma is important, but stigma seems like a column in the middle of the room that you can't do anything about. But really, stigma, if you look it up in the dictionary, is negative attitudes. And negative attitudes we can change. And we try to do that by partnering with communities, by talking with legislators, by bringing healthcare providers in together. So those barriers between academia and lawmakers and people with lived experience are really breaking down. And we're building an entire community with all those people involved.
That last statement that Jill made about stigma, to me, is so important, because I think a lot of times we give stigma unwarranted power because we do treat it like it's this impenetrable, impassable thing, when stigma really is a narrative that a community has created for whatever reason. And more often than not, it's a narrative that's created as a survival tactic. I mean, I think about my community, where I was taught if you acknowledge depression or anxiety, you're not a strong Christian. You should be having more faith. Well, we didn't have psychiatrists and psychologists in Plymouth, North Carolina. We had a church on every corner. And so we adapted to what we had available to us, and we created a narrative around that. And so I think one of the things that we have to do too, and especially as we're engaging with communities that are new to us, is we need to understand the roots of stigma, because it also shows up differently in different communities. And so we have to try to understand what's behind it. And if we understand what's behind it, it's then treating that community with respect rather than treating them like they're ignorant. And as we try to acknowledge and understand the root of it and then address it, it allows us to address it with research, with literature, to speak to what the issues are, as opposed to us assuming that we know what the issues are and just trying to overpower and overwhelm a community with information.
And I can imagine too, Vic, on that point, is that mental health and suicide is such an individualized thing and understanding. And so I wonder how, you bridge even that global to local context of trying to address those root causes. Like, I can just imagine that looks so different from, Plymouth, North Carolina to like Zimbabwe, right?
Yes.
Like how do you think about addressing the root causes from a sort of global to local context in that way? And how is that difficult?
Yeah. And I'm glad you used the example from Plymouth to Zimbabwe, because one of the things that we did earlier this year, so we had, I had mentioned that one of the programs we created was a program called Soul Shop for Black churches. And what Soul Shop is an 8-hour curriculum that teaches faith leaders in the Black faith community how to talk about suicide, how to recognize the signs and symptoms, how to connect people with help, and how to address it, how to have conversation with folks who may be struggling, and not just those folks who may be suicide attempt survivors themselves, or folks who have suicidal thinking, but also those people who have lost folks to suicide, may be worried about someone who may be experiencing suicide. Well, 2 years ago, in October of 2023, there was a gentleman who traveled to Asheville, North Carolina, from Cameroon, Africa, to be trained in this soul shop, because he was overseeing some 200 pastors in Cameroon, and he wanted to learn how to address suicide prevention, because they don't have a lot of psychiatrists. I was told they only have 17 psychiatrists across a whole country.
Wow.
Now, I haven't counted them, but that's what they told me. But so he came to be trained in it. He went back to Cameroon, and he did a couple of training sessions and thought it was really successful, but he wanted more trainers, and he could not train trainers because I was the only person that was authorized to train trainers for the Soul Shop program, as one of the people that had helped create it. And so I went over to Africa with him in January of this year. We spent 10 days on the ground in Africa. We trained 92 faith leaders in Cameroon, Africa, on Soul Shop for Black churches. It was the most amazing experience. And there were pieces of it where culturally we had to tweak pieces of it, because there were certain things that didn't resonate with them, either because they didn't have the language or because the culture was slightly different. But again, because it has those core tenets of these are the things that impact everyone that's experiencing suicide. The only things that we're really tweaking are the things that make it culturally relevant, and the things that make it relatable to them. And so it makes it, it gives us the ability to do that. And so again, this was a program that we took that was created here in America, and with some simple tweaks, it was able to work on another continent. And so as we're thinking about creating programs here, whether it's for the Black community, Hispanic community, the Asian community, the core pieces are the same. It is how do we make it relatable and make it fit the lived experience of the groups that we're working with. One of the things we're finding, for example, with the AAPI community is even more so than some other communities, there's a real generational gap there in how they talk about or are willing to talk about mental health and suicide. We have a young group that for the most part is more open to the conversation, and that's true across most communities. But we have an older generation that is very much opposed to having the conversation. And so again, for them, it's how do we craft it in a way that's palatable to that community and that makes it relatable to that community, and not in a way where I'm coming in and saying, well, you're wrong for not talking about it. We're just gonna, come in and start having this conversation. So it really is about, how do you take those core principles that we take across all communities and really make them and present them in a way that builds relationship with that community. And one of the ways that we build that relationship with the community is by respecting what that community believes in. The way that I approach this is I think about the characteristics of a community, and then how do we lean into their space, recognizing that communities have this shared sense of consciousness, that they have this feeling that whatever happens to you impacts me. How do I create that kind of relationship with the community? Emotional identification. Communities have a feeling of belonging together. So how do I create that sense of belonging with them unless I'm willing to sit quietly and just be a part and learn and grow with them? And then they have those common ends, and that's that respect for language and culture and customs and traditions. We are constantly evaluating and reevaluating even the resources that we're putting out, because we learn more. As the research grows, we grow in our ability to engage communities. And so even with the programs that we've developed, we're constantly bringing those trainers back together and saying, what are you learning from the audiences that you're engaging with? How do we need to tweak the program? How do we need to go back and and redo some pieces of it. And so that means that we're oftentimes having to pivot, even if it means messaging something that specifically says to a community, we're still here. We have not forgotten you. But all those things are part of the ongoing process.
As we sort of wrap here, I'd love to know from both of you, and maybe Vic, I'll start with you, but is there an insight or a learning or a question that you want to leave our listeners with today, just based on sort of your experience in this work and your role as a system catalyst?
Yeah, I think, one of the lessons that I have learned, especially as I've gotten more involved in this work, is I know what the data says, but I was not prepared coming in for how many people that I knew, family members, people I went to high school with, relatives, coworkers that would come to me and say, I know you're in this space, I know you do this work, and I've been struggling, or I'm worried about a family member who's struggling, or I had this experience I've never told anybody about. Suicide impacts all of us in some way. And so the thought I would leave with anyone out there is, if you're experiencing mental health challenges, by all means, get support. If you're experiencing a mental health emergency, if you're in crisis, please dial 988 to be connected to a trained counselor who can connect you with the help, with the services, with the support you need when you need it, because you matter, your life matters, your pain matters, and you are not alone.
Thank you, Vic. Jill, anything you want to leave us with?
Well, all of what Vic said. And I guess what I want to say is, how can you help is, leave the judgment at the door. It's all about compassion, which is understanding that somebody is struggling, but you also understand that they could feel better. It's different from empathy, which is, it's a form of empathy, but it's like, I know there is hope and I'm going to be by your side. So compassion, respect for the person you're talking to and for yourself. And then patience and persistence. Because a lot of times people say, no, I'm fine. Nothing's going on. And you need to know to come back and try again. And sometimes when people aren't feeling great, they're pretty, it's not always great to be with them. But come back, because remember, you have compassion and respect for them and you care about them. And come back and be patient. Because the person you're seeing who's struggling is not the person necessarily that you usually see. And they don't have access to their usual coping. So we can't just wait for them to come to us for help. And so just asking, how are you? Knowing that I'm walking by your side, like Vic said, that you're not alone, can have a huge impact on saving someone's life.
Wow. Thank you both so much. This is just such a wonderfully timely conversation, and also just a wonderful reminder for all of us to, remember that we are walking side by side with people, and there's people that we love that we could probably call and check on today. So thank you both so much. I really appreciate you coming on.
Thank you so much.
Thank you for having us.